Listen-only mode.
Good evening, everyone. Welcome to tonight's webinar on ultrasound assessment of native renal vessels, presented by Dr. Margarita Revzin. At the conclusion of this webinar, participants should be able to describe renal vascular anatomy and Doppler evaluation of the renal vessels. Participants should also be able to discuss the role of duplex ultrasound in the diagnosis of renovascular hypertension and post-revascularization surveillance, as well as other vascular disorders and pitfalls in diagnosis. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Revzin and Kathy Minton have no disclosures. During tonight's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Margarita Revzin.
Thank you everybody for joining me, and today we're going to talk about ultrasound assessment of native renal vessels. Our objectives would be to review normal and variant renal vascular anatomy. We'll take a look at the key techniques and protocols for Doppler evaluation of the renal vessels, and we'll discuss role of Doppler ultrasound in the diagnosis of renovascular hypertension and post-revascularization surveillance. We'll discuss other pathologies and pitfalls in diagnosis. I have nothing to disclose. So first of all, we would like to start with the evaluation of the anatomy of the renal vessels. A right renal artery is usually longer than the left one and has a downward course which transverses behind the IVC and right renal vein, as it's seen on this image. So right renal artery is long and it's posterior to the right renal vein. Left renal artery is more horizontally oriented and has a direct upward course to the superiorly positioned kidney. Then the main renal artery divides into the 5 segmental arteries, which are posterior, apical, upper, middle, and lower segmental arteries, which then divide in the interlobar arteries within the parenchyma of the kidney, and then further down divide into the arcuate arteries around the medullary pyramids. Later on, these arteries will also divide into interlobular arteries.
Dr. Revzin, I'm sorry to interrupt you, but your slides do not appear to be advancing.
Oh, where are you right now? Because my slides are with me.
It's showing your title slide. It looks like on our screen it's not in slideshow.
What can I do? Because on my screen everything is advancing. Do you see my first slide? I'm right now in the first slide.
What I'm seeing right now is your title slide. Anyone in the audience seeing the slides advancing, it could, maybe the problem is on my end, and I'm so sorry for the interruption.
I'm just waiting for the response.
Yeah, it looks like other people are having the same problem. Um, I, I wonder at the top if you could click on slideshow. It may be that the way your computer is set up, it's showing them on the other monitor.
Uh, no, I'm actually on a regular. I'm not sure what can I do right now just because I can't change the display mode otherwise. Let me see if I can do the settings. Okay.
Seems like the more convenient these technical assists get, the more likely they are to create all sorts of headaches.
Yeah, so let's see if I can do this. Maybe that's going to be better. Oops. Okay. Okay. Can you see me right now advancing?
Yes, perfect.
Okay, great.
Thank you very
So
much.
I'm just going to go into the renal artery anatomy. Okay, and again, to reiterate it, we have a main renal artery on the right that has a longer course that is more downward course, and the renal artery is located posterior to the renal vein. And we have a left renal artery that is shorter and has more upward course that goes towards the superiorly positioned kidney. And we have main renal artery that divides to the segmental renal arteries, then to the interlobar arteries, and then into the arcuate arteries around the pyramids, and then interlobular arteries. So one thing that is everybody has to keep in mind is that renal vessels may have a variant anatomy. We noticed that there is a duplicated main renal arteries, and polar or aberrant renal arteries may be seen in up to 22% of individuals. Polar renal arteries are the ones which take off from the aorta or any other vessel, sometimes even celiac or mesenteric vessel, and they usually have an entry point other than the hilum into the kidney and supply one of the poles of the kidney. On the contrary, accessory renal arteries, they can also take off from the aorta separately or from other vessels, but they do entry into the parenchyma of the kidney through the hilum. And in up to 30% of cases, we may not diagnose them or find them with ultrasound. And that, of course, decreases sensitivity of ultrasound to diagnosis of pathology of renal vessels just because of presence of these vessels, accessory and aberrant renal arteries. When we evaluate renal arteries, we want to always take a look at the waveforms. The usual classic pattern of the main renal artery waveforms is low resistance waveforms, where we have a continuous flow through systole and diastole, and we have a good amount of end-diastolic flow at the end of the cycle. And this is because the renal arteries supply end organs, and such as kidneys, and they always need oxygen throughout the entire cycle, cardiac cycle. We can also, based on the waveforms, calculate peak systolic velocities and also end diastolic velocities in the renal vessels. And we can also calculate resistive indices based on this, using this formula where the peak systolic velocity we subtract the end diastolic velocity and divide it by peak systolic velocity. That's how we can find what is the resistive index. Normal range of peak systolic velocity in the renal arteries is usually 60 to 100 centimeters per second. When we evaluate renal arteries, we would like to use the 2.5 to 5 megahertz curved array transducers. These transducers help us to see the deep structures in the abdomen and pelvis. and the renal vessels are located somewhat deep in the body of the patient or person, and therefore the curved transducers are utilized. We wanted to always optimize our grayscale images to make sure the brightness is correct so we can assess the echogenicity of the renal cortex, and we also wanted to use liver and the spleen as our acoustic windows. There are several approaches that we can utilize. This is a midline, transverse midline approach, where we have the origins of the vessels very nicely displayed with this approach. Sometimes this could be limited by bowel gas. The only thing you have to do is just to use your transducer and apply some pressure on the abdomen and very slowly, gradually advance your transducer in the abdomen so that you displace bowel and also displace the bowel gas. This is a coronal approach that also gives you a nice view of the main renal vessels, and on the right and on the left, and utilized when there is a lot of bowel gas and you can't avoid it otherwise. In some cases, when you can't find the renal vessels, you can use your sagittal or long axis view, where you have IVC in a long view, and just behind it would be a right renal artery en face, which looks like a circle. Once you find it, you can elongate on it and try to visualize the entire vessel. And that's how you can find the renal arteries better. And all of us know about the coronal banana peel view, where we have aorta in the coronal view, and we can see the takeoff of the right and left renal arteries simultaneously, and it looks like a peeled banana. We use usually not only grayscale, but all the modes such as color and spectral Doppler. With color mode, we assess the patency of the vessels and also direction of flow, and we can also evaluate for any possible aliasing within the vessel. We wanted to optimize our color Doppler. With color gain, we wanted to make sure that the vessel is filled entirely with the color. We wanted to optimize our PRFs and to make sure also it's not set to very low numbers, so you're not going to have aliasing all throughout the vessel, but it's going to display nice laminar flow. And also we use low filters when we evaluate on color Doppler. On a spectral Doppler, what we can optimize is a sample volume, where we wanted to decrease it to up to 2 millimeters, so that you don't have overlap and contamination with the venous flow. And your waveforms are nice and clean and do not have any contamination from the venous flow. Also, we can make our the graph much bigger and make sure that the waveforms fill up almost the entire graph, so that we can evaluate very well the pattern of low resistance waveform of the renal arteries. When we do in the spectral Doppler, we always wanted to make sure that our sampling is performed with the angle of inclination of less than 60 degrees. And this is because of we wanted to avoid increase of velocity due to abnormal cosine theta that is used in calculation of velocities. So you really wanted to have your angle of inclination of less or equal to 60 degrees. Power Doppler is utilized usually for evaluation of global perfusion of the kidney. We wanted to see that the entire renal cortex is perfused, and if there are any abnormalities visualized and no flow is seen within part of the cortex, you may suggest that possibly this is either due to an infarct or could be due to the abscess. And here correlative images on CT also confirm that there is a decreased perfusion in this kidney in particular that corresponds to the infarcted area. Renal Doppler ultrasound protocol includes complete evaluation of the kidneys. We want to first to examine if the kidney is healthy or can be revascularized in the future or not. So we pay attention to the size of the kidney, we pay attention to the thickness of the cortex of the kidney and the echogenicity of it. Then we look at the aorta, and we wanted to make sure that there is no dissection in the aorta and we don't see any aneurysmal dilatations, and we evaluate the degree of atherosclerosis within the aorta. And we evaluate then branches of the aorta, and we wanted to see that the main renal arteries don't have a big plaques at the origin of the vessels. And also we wanted to check for presence of duplicated renal arteries, if they're present or not. And we assessed the renal vessels on color Doppler, looking for any possible aliasing or abnormalities. So the protocol also involves evaluation of the peak systolic velocities, and we obtained the peak systolic velocities within the aorta first at the level of the main renal arteries. And this will be later calculated for our ratio from renal artery to aortic ratio. And then we also want to obtain peak systolic velocities at the origin, at the proximal portion of the main renal artery, the mid portion, and distal or hilum. Later on, we're going to also assess waveforms in the cortex or also in the segmental vessels within the parenchyma of the kidney. And usually we get 3 segmental waveforms and decide of if there are any Tardus parvus waveforms present, and we'll talk about it later. So also when we evaluate renal vessels, we wanted to pay attention to any abnormalities within the vessels on color Doppler. And on color Doppler, we're looking for things like color aliasing and buoy artifact within the tissue surrounding the vessel. And also, if it's present, we're going to apply and do the spectral Doppler at the level of the abnormality and interrogate this area and see what are the peak systolic velocities in this region that is suspicious for stenosis. So hypertension is a very common problem among the population, our population. In 90%, the patients have essential hypertension. However, up to 5% patients may have a renovascular hypertension. And if it's left untreated, it may progress to decrease in renal function. But this is a surgically curable cause of hypertension. We can either cure the hypertension and maybe salvage renal function. So renovascular hypertension is characterized by abrupt onset. It's very severe, accelerated, and uncontrolled hypertension. Blood pressures usually are over 110 millimeter of mercury, and it's a diastolic blood pressures. And there is a lack of response to 3 drug regimens. Usually this disease affects patients who are younger than 30 years old and older than 60 years old. There is usually no family predisposition, and hypertension is seen in the setting of renal failure. The causes of renal artery stenosis are usually atherosclerosis. In up to 90% of patients may have a renal artery stenosis due to atherosclerosis, and about 10% patients who have fibromuscular dysplasia. Renal artery stenosis usually is associated with development of renal vascular hypertension, and therefore assessment for renal artery stenosis is very important. Also, renal vascular hypertension is associated with renal insufficiency and myocardial infarction, CHF, stroke, and death. Early diagnosis is very important to prevent that renal function, and intervention is usually a treatment of choice. So this is a diagram that helps to understand the relationship between the renal artery stenosis, development of hypertension, and development of renal failure. When all 3 of these components are present, then we can call that there is a renal vascular hypertension. So therefore, not all of the patients who have renal artery stenosis have renal vascular hypertension. Most of the patients actually are asymptomatic who has renal artery stenosis. And diagnosis of renal vascular hypertension requires documentation of physiologic abnormality as well as structural narrowing in the vessel. Again, it is a potentially correctable cause, and therefore we need a non-invasive test that can help us to diagnose potential stenosis within the main renal vessels, and therefore alert the physician to further treatment, probably by intervention. There are multiple different modalities available for diagnosis of renal artery stenosis. However, we have some limitations with all of these modalities, such as CTA and MRI and Doppler and renal scintigraphy. The ultrasound provides some advantages. This one include non-invasive test. It's inexpensive test. It's readily available. It uses no ionizing radiation, and there is no nephrotoxicity associated with it. So what also is good about ultrasound assessment is that it provides us anatomical evaluation of the kidneys, including their size. If the kidneys are less than 8 centimeters, usually there is no benefit in revascularization, so it helps us to assess who would be a good candidate. It also allows us to see if there is any asymmetry in the kidneys, which is going to be implying on presence of renal artery stenosis in that kidney that is potentially atrophic. And also we can assess echogenicity. Also, in addition to anatomical evaluation, it provides us with some information about physiology, and we can evaluate peak systolic velocity and resistive indices, both of which help to diagnose renal artery stenosis. On ultrasound, we see main renal vessels, main renal arteries in up to 90% of patients. And ultrasound demonstrates very high sensitivity and specificity for finding of renal artery stenosis. It is always a complementary modality when we cannot see origins of renal vessels, and also when we have some limitations such as obesity or too much of bowel gas. These patients will undergo other evaluation with other modalities for renal artery stenosis. We use most of the times several diagnostic criteria, and combination of this criteria is really optimal for diagnosis of renal artery sclerosis. So what is our goal with ultrasound? We want to identify focal elevation of peak systolic velocity at the anatomic site of stenosis in the main renal artery. And also we want to identify delay in rate of systolic acceleration distal to stenosis. And usually it's an intraparenchymal artery such as segmental or interlobar arteries. We can calculate our acceleration indices and acceleration times and assess the waveforms within the segmental vessels to decide if there is a significant stenosis maybe there and maybe we are missing it. So these are the different criteria that we utilize for evaluation of renal artery stenosis. Peak systolic velocity, renal to aortic ratio, presence or absence of Tardus parvus waveforms, and resistive index. However, resistive index is more non-specific, as we found later. So for the peak systolic velocities, we use usually criteria of 200 centimeter per second, which is once you're above this threshold, we consider that the vessel is stenotic. It's a direct criteria and has a very high and good specificity and sensitivity, as you could see, with 85% of sensitivity and 92% in specificity. Renal to artery to aortic ratio is also a direct criterion which you use all the time to make sure that we compensate for hemodynamic variability between the patients. So, for example, in patients who are younger, they usually have a higher peak systolic velocity in the aorta and branch vessels. Therefore, we're going to use this ratio to make sure that we're not going to overcall these patients with the renal artery stenosis. In elderly populations, sometimes they may have cardiac disease and poor cardiac output, and they will present with lower peak systolic velocity in both aorta and main renal vessels. However, the ratio will help us to define if these patients truly have renal artery stenosis, even though peak systolic velocity may not meet the criteria for stenosis. So we found that a renal to aortic ratio, when it's greater than 3.5, works the best with a very good sensitivity and specificity of over 90%. When we use both peak systolic velocity and renal artery to aortic ratio, then the specificity is very high and sensitivity is also very good for identification of greater than 60% diameter stenosis in the main renal artery. One of the indirect criteria is Tardus parvus waveform, and it represents a damping of the waveform in the segmental vessels. And we can either subjectively look at the waveforms, or we can estimate acceleration times and acceleration indices. And here's the example of how to evaluate this. So acceleration index is a slope of line from the onset of the systole to the early systolic compliance peak right here. And if we see that the slope is pretty steep, then there is a presence of Tardus parvus waveform. When acceleration time, we can calculate from the beginning of the systole until we reach the point of the early systolic compliance peak. And this time, right here, would let us know if there is a delayed upstroke of this waveform. So it's a length of time from onset of systole to the ESP. If it's greater than 70 milliseconds, then it's abnormal. And subjectively, we can just look at the waveforms. And if we see that the waveforms are rounded and there is a really no nice peak that is 90 degrees to the baseline on a graph, then we consider that this is a Tardus parvus waveform. Once we are assessing for renal artery stenosis, again, we're looking for the secondary signs in addition to the direct and indirect criteria. So this image represents that there is an aliasing within the proximal portion of the main renal artery, and we should interrogate this area because it implies on presence of very high peak systolic velocities. On this image, we see not just aliasing, but also tissue vibration artifact or buoy artifact in the color Doppler. On this image, we see also spectral buoy artifact, which also represents a display of very small peak velocities that are seen in the stenotic portion of the vessel due to very turbulent flow, and some of the red blood cells are moving forward and some backwards, and they all have different peak systolic velocities, and they're going to be represented on this graph. And another one is shaggy waveforms that are usually seen right after the stenosis, and also is just because there is a turbulence of flow and multiple different velocities seen within this vessel at the level just beyond the stenosis. Again, this is an example of renal artery stenosis where we have aliasing within the vessel. We have a very high peak systolic velocity in the origin of the right renal artery, up to 602 centimeter per second. And when compared to the aorta, aorta has a very low peak systolic velocities at the level of the main renal vessels. When you calculate the ratio, then you have a almost over 18 ratio. Both of these criteria would comply with diagnosis of renal artery stenosis, and then it should not be any question about it. On this example, we see not only elevated peak systolic velocities and high ratio, but also presence of Tardus parvus waveforms in segmental vessels. This is a different patient who is 67 years old, male, and he came with a hypertension and increased creatinine. And if you look at the origin of the right renal artery, in the mid-renal artery and hilum, all of these portions of the vessel demonstrate very high peak systolic velocities that would meet the criteria for stenosis, and also high ratios that I didn't display to you. On the left side was exactly the same problem. We had a very high peak systolic velocities. However, distally, in the segmental vessels, the the waveforms were not really Tardus parvus waveforms, and it's okay sometimes not to see a Tardus parvus waveform, just because it showed that Tardus parvus waveforms are very specific but not necessarily sensitive. So even in the presence of significant stenosis, Tardus parvus waveforms may not be seen. But if you do find them and you didn't diagnose elevated peak systolic velocity elsewhere in the main renal artery, then probably you should go back and look again, and also look for any possible accessory vessels if Tardus parvus waveform seen only in one portion of the kidney, in the upper or low pole. This is corresponding images on the CT, and we see large calcified plaques at the origins of main renal arteries bilaterally. So the pitfalls for renal artery stenosis include presence of the variants of the renal arteries, where we may miss potentially accessory renal artery that has significant stenosis within it. Also presence of high or low output states, such as thyrotoxicosis, where there is a high output state. In this scenario, usually ratio works really well. And also in patients with sepsis and CHF, peak systolic velocities may be systemically very low, and therefore even there is a stenosis in the main renal artery, it may not reach the peak systolic velocity within it may not reach the criteria for stenosis. Also, incorrect angle of inclination may be a problem and cause spuriously elevated peak systolic velocities in the normal vessel. Arrhythmia can be a problem as well. We wanted to use either very high peaks or middle peaks, but not necessarily low peaks for evaluation of peak systolic velocities. Just also keep in mind that sometimes vessels are tortuous, and there is a collateral flow can be seen in occluded vessels. This is an example of duplicated renal arteries or accessory renal arteries, where we have two origins of the vessels, and if you could see, both of them enter into the hilum, and one of the vessels was interrogated and showed very high peak systolic velocities, and the other vessels show normal peak systolic velocities. So if you would only see one, then you would definitely miss the renal artery stenosis. And this is an example of tortuous vessel, and if peak systolic velocities are taken from the area where it takes a very sharp turn, then peak systolic velocities may be really elevated, but there is no stenosis here. Limitations of ultrasound is usually due to bowel gas and obesity, and presence of significant calcifications within the aorta and main renal vessels that may obscure the visualization of the lumen, as well as a Doppler signal may be also dimmed. And it is an operator-dependent test, so it really requires a lot of experience and a lot of years of experience. So main renal arteries, again, remember that they may not be seen in up to 30% of patients. If you can't find it, if it's too much of bowel gas, just terminate the examination and consider other modalities. So when we do find renal artery stenosis, we have to think about who would be the one who benefits from intervention, who is the candidate. And usually it's the patients who have accelerated refractory or malignant hypertension in the setting of renal artery stenosis, or those who demonstrate decrease in renal function, dramatic decrease. And also those patients who have recurrent or unexplained episodes of CHF or flash pulmonary edema, and of course the ones who have a fibromuscular dysplasia as a sort of underlying problem. So there's still controversy exists in regards to who should be revascularized and is it actually beneficial or not. There are multiple prospective randomized trials were performed as astral and coral studies, and some of them showed that there is no significant benefit of stenting, and patients do not improve with their hypertension, and there is no restoration of renal function. Also, it was somewhat found that there are some complications related to the procedure, and therefore sometimes medical treatment is a preferable choice. However, all of the studies had some flaws to it, and the reasons that could be why patients did not improve is because maybe revascularization was done on those patients who already had end organ damage, or the medications that developed, the current medications are much better than the ones which we used in the past. And also maybe some patients develop severe complications from the intervention, and those who developed in-stent stenosis after stenting. So therefore we use sometimes some factors that can help us to decide if the patient should undergo revascularization. And that would be assessment of the size of the kidneys. So Effective revascularization would be if the kidney is normal in size, over 8 to 9 centimeter. Also, if there is a normal serum creatinine of less than 3 to 4 milligrams of deciliter. And also if there is a renal function preserved on scintigraphy, and also glomeruli are preserved on renal biopsy. So this is an example of patient who, before stenting, demonstrated Tardus parvus waveforms in the distal vessels and high peak systolic velocity in the origin of the left renal artery. And after stenting, the peak systolic velocity normalized, and also there is a normalization of the waveform pattern in the segmental vessels. So that was a very successful revascularization. In-stent restenosis is a very common problem and occurs in up to 20% of patients after stenting at 6 months and after. And usually MRI and CTA are not preferable modalities for evaluation of stent patency and also physiological any abnormalities within the stent. There are some variable criteria exist right now that are utilized with ultrasound for evaluation of stents. But we generally use peak systolic velocity of 144 to 240, considered to be within normal limits. After that is abnormal, and ratios below 3.2 is still normal. Presence or absence of Tardus parvus waveforms is also important to notice in the segmental vessels. So post-stenting, we can have the development of in-stent restenosis, and that would be presented as elevation of peak systolic velocities in a stented vessel when compared to the baseline that is obtained right after stenting, and also presence of secondary signs such as aliasing and Bruy artifact on spectral Doppler. This is an example of a patient who had a stenting before. On grayscale, we see that there is soft tissue that is filling the stent, and when we put in the color Doppler doesn't fill in the entire stent, and there is some aliasing present at the origin of the vessel. When we optimize the images a little bit better to sort of see a better feeling of the distal vessel, we can see that there is a very poor feeling of the more proximal stented portion of the vessel, and there is a lot of aliasing. When we interrogate this area, we see that the peak systolic velocities are very high. So this patient underwent angiogram and demonstrated a breakage in the stent. And this patient originally had 4 overlapping stents placed, and this angiogram showed that there is a fracture of the stent arteriogram. So what happened with in this kind of situation is that we take in the fractured portion of the stent and we put in it somewhere else and park it there and sort of leave it because you can't really remove it. So this was left in the external iliac artery. After the procedure, the patient returned to our ultrasound suite, and then we evaluated this patient, and we saw that now the stent is filled very nicely with the color Doppler, and the interrogation of the vessel, of the stented portion of the vessel, demonstrating normalization of the peak systolic velocities. So we're going to switch gears right now and talk a little bit more about other reasons of renal artery stenosis, as well as other pathology that may affect the kidney and renal vessels, and something that we have to keep in mind when we evaluating renal arteries. So this is an interesting case of 65 years old female who had a partial nephrectomy for renal cell carcinoma, and now she had a new onset of hypertension. So when we look on the grayscale, the vessels look very nice, and on color Doppler, the right renal artery is filling nicely, and on the left, although the vessel is patent and seen throughout its course, we see that there is some aliasing within the distal portion of the vessel. And this is magnified view of this. So when we interrogated this area, we saw that the peak systolic velocities were markedly elevated, over 300 centimeters per second, and Tardus parvus waveforms were seen more distal in the segmental vessels. And patient underwent CTA where it was appeared to be maybe aneurysmal dilatation in the area where we saw abnormal. Patient underwent arteriogram of the left mean renal artery, and it showed that there is a web-like lucencies within the aneurysmal or dilated portion of the vessel. So the decision was that probably the patient had clamping during the surgery for the partial nephrectomy. You could see the scar here, and that caused probably either scarring or maybe partial dissection within the vessel. The patient had a stent placement at the area of abnormality, and after that ultrasound was performed and demonstrated normalization of peak systolic velocities in the distal left renal artery. And patient also came back for follow-up a few months later, and she said that she didn't have any more hypertension. So it was a very pleasing outcome. This is a different patient who had also a hypertension, and when we interrogated the main renal artery on the right, we saw that there is a little bit of a irregularity in the pattern of the color Doppler within the vessel, in the more mid and distal portion of the vessel. And this is a string of pearl sign that is usually seen on power Doppler in patients with FMD. Sometimes we may see this also FMD pathology as a lone segmental narrowing of the mid and distal aspect of the main renal arteries. Again, if you interrogate these vessels, usually they demonstrate very high peak systolic velocities. But you can notice that the abnormality is not at the origin. The origin is all normal, because renal artery stenosis that is due to atherosclerotic disease will have a problem in the origin. With FMD, the patients usually will have a problem somewhere more distally to the origin. And correlative imaging demonstrates also corkscrew appearance or string of pearls appearance on on other cross-sectional imaging. So what is FMD, or fibromuscular dysplasia? It's usually a proliferation of smooth muscle cells and fibrous tissues in the wall of the vessels, and it affects medium-sized arteries. Most commonly, females are affected, younger population. Therefore, you always wanted to see, okay, are you looking at the younger patient or older patient? The elderlies will have atherosclerosis. Younger patients, female patients, will have FMDs. If you become concerned about FMD, then not just look at the renal arteries, but go further down and see if mesenterics may be affected or carotid arteries are affected, because sometimes you could see that the disease also involves other vessels. This also can be seen in up to 30% of cases with cerebral aneurysms. And again, management usually is angioplasty of the stenosis segments. We don't put stents in the patients with FMD. We usually use angioplasty. This is another patient with FMD, and on a grayscale, we can see that there is a cystic regions in the hilum of the kidney, and then when you put the color Doppler, they all fill in and connect between themselves. And if you interrogate these areas, you will see that some of them will display high peak systolic velocities, and how some of them will show normal velocities. That correlates with the areas of aneurysms and dilatation. Other things that we have to be aware of is the presence of large masses in the kidneys that could be neoplasms, either malignant or benign neoplasms. And these masses can cause a mass effect on the vessels that are coming off from the hilum. And that's the patients who will also present with hypertension and renovascular potentially hypertension, but these patients will not show any atherosclerosis or may not show any abnormalities at the origin of the vessels, but the problem would be at the hilum because of the mass effect. Again, this is all elevated peak systolic velocities and flattening of the waveforms in the vein. All of this kind of points to the the mass-related effect of the renal cell carcinoma in this patient. Corresponding images demonstrate also a big mass with some actually aneurysms within the mass that causes mass effect into the hilum. This is a different patient, but with similar abnormality or similar findings, and again presented with hypertension, found to have a high peak systolic velocities in the hilar vessels, and this mass corresponds to the coalescence of multiple lymph nodes in this patient with a history of lymphoma and recurrence. And this is a correlative PET CT that demonstrates this big, large mass that causes mass effect on the kidney and hilum of the kidney. This is a transplant kidney where we have a large area of abnormality that correlates to a hematoma. Patient had the biopsy and developed a hematoma in the surrounding soft tissues, and again that caused abnormality in the vessels with a high resistance waveforms just proximal to this hematoma and mass effect, and also abnormal waveforms a little bit more distal to it. And this is a different patient who was found to have a cystic area in the region of the parenchyma of the kidney. And when you see a cystic areas, you always want to put a color Doppler. And if it fills in, you wanted to interrogate this vessel with a spectral Doppler and see what kind of waveforms are you going to find. Because in this patient particularly, you may find arterialization of the waveforms in the vein and very high peak velocities within the vein and within the arteries as well. And this was AVM and AV fistula sort of abnormality within the kidney. The patient didn't have any prior interventions and or just developed it either spontaneously or maybe congenitally. And this is a different patient and who had a biopsy. This is a native kidney, very iatrogenic kidney. That's why the biopsy was performed. Patient had a decrease in renal function. And what we see is, again, the cystic area that we interrogate with color Doppler and spectral Doppler, and we find that there is a filling of this area with a color, yin-yang flow within, and also to and fro flow within the neck of this pseudoaneurysm that developed after the biopsy. And to be sure, you can always look at the prior imaging, like in this patient. And this is a prior exam, and that showed that there is no pseudoaneurysm on the prior imaging. So it was related to biopsy. The other pathologies that we may see is not just the pseudoaneurysms or aneurysm within the parenchyma, but also in the hilar vessels could be a true aneurysms. Sometimes aneurysm can be detected only because you see the peripheral calcifications in the wall of the aneurysm, and when you fill it, you will see that there is a filling of this area, but they could be very subtle, these aneurysms, and only if you know about their existence, you may be able to diagnose them and actually locate them. And in this patient, it was, I don't know why it's not playing, but it was showing that there was an aneurysm at the hilum, and also the patient had also aneurysm somewhere else on the other kidney, more distally, and this patient also had aneurysm intracranially at the basilar confluence, as well as at the communicating artery. So given that there is an intracranial aneurysm present, as well as parenchymal aneurysms and vascular aneurysm, then you have to suspect either this patient may be having FMD, or maybe these patients have Ehlers-Danlos syndromes and disease. This is another one, also peripherally calcified aneurysm, and again, you wanted to put the color Doppler and see that it fills in, and you know, the main renal artery is absolutely normal in its proximal and mid portions, and only distally you may detect these abnormalities. On a plain film, you can also confirm the diagnosis just seeing this peripherally calcified aneurysm at the area that is projected over the renal hilum. So renal artery aneurysms are not as common as you would think, but usually represents a dilated segment that is at least twice larger than the diameter of the normal renal artery. Average age is 40 to 60 years old and have a female predominance, and that's because of the majority of patients who will have this have FMD. If they're symptomatic, they may present with hypertension or pain or hematuria and renal infarction, and they have a potential for rupture and fistulization when they increase in size. Most of them are extraparenchymal, and some of them are intraparenchymal, and there are different causes of it. depending of if it's related to a trauma aneurysm or related to congenital abnormalities or infection. But true parenchymal renal artery aneurysm usually are managed with nephrectomies or coil embolization. So we'll move on to other things that we can potentially see on when we evaluate renal arteries. And in this patient, the kidney is appears to be normal, the portion that is visualized, but next to it looks like maybe multiple cystic lesions seen. And what you again want to do is put the color Doppler and make sure that this is not filling. In this patient, all these cystic areas were filling and confluent, and this is a patient who had a portal hypertension and had a splenorenal shunt with multiple vessels present between the kidney and the spleen. Other things that may affect the main renal arteries is a dissection, and usually dissections represent an extension from the aortic dissection, and they may also dissect into the main renal arteries, so it's important to make sure you interrogate these vessels and look for elevated peak systolic velocities that will tell you that the main renal artery is compromised because of the true lumen is very narrow. Sometimes you may see to and fro flow within these vessels just because probably it's supplied by the false lumen. So you want to also assess the kidney and kidney perfusion in this kind of situation, and just make sure that this patient is given a good management for this problem, and everybody knows about dissection into the renal arteries. So again, renal artery dissection occurs mainly after direct vessel injury, either trauma, may be seen with hypertension in the setting of hypertension in patients with FMD or atherosclerosis. Spontaneous renal artery dissection is very rare and can be openly unrecognized. Clinically, this patient may present with acute low back pain, flank pain, or hematuria. And the symptoms usually are misleading, and it's sort of the diagnosis can be found only with imaging, such as either ultrasound, CT, or MRI. We're going to move on to other pathologies such as infarction that can be also diagnosed on both grayscale and color Doppler imaging. And infarction can be seen either as an area of hypoechogenicity or hyperechogenicity. If it's an old infarct or chronic infarct, usually it becomes more fibrotic area, and this is non-functioning portion of the kidney, and becomes more echogenic. In a more acute form, the area can be more hypoechoic, so it's variable presentation in an infarct. You put your color Doppler and you will see that there is basically no perfusion to the cortex in the area of infarction. Sometimes Doppler ultrasound can help us to diagnose malignancies, either renal cancer like in this case, or we can have oncocytomas, angiomyolipomas, and we can also see if this is a normal variant of column of Burton versus mass. And once you see this, you can refer the patient for further management with the nephrology section. When we see that there is a Tardus parvus waveforms as seen in bilateral kidneys, in the segmental vessels, as well as main renal arteries and in the aorta, think about a more central problem, like stenosis within the aorta, like in this patient with cartation. So something to keep in mind that if you don't find any renal artery stenosis at the origins, if bilaterally it's abnormality, and the aorta is also demonstrates abnormal waveforms, think about more central problem. This is an example of a patient with a nutcracker syndrome, and in this situation we have compression between the aorta and SMA of the left main renal artery, and in this patient usually the patient's symptomatology is hematuria and abdominal pain. And this diagnosis is really well, could be done by using ultrasound, just because we can detect abnormally elevated peak velocities within the vein, and also like presented as alias in this region. And also we can really assess how the SMA is taken off acutely from the aorta and has a very small angle between the takeoff and of the SMA and the aorta, which would be diagnostic. So whenever we see that the angle between the SMA and the aorta is less than 17 degrees, then you can start thinking about nutcracker syndrome, especially if the patients are symptomatic, present with unexplained abdominal pain. And you can see the alias in the area, and also you can in the area of stenosis in the left main renal artery, and you can also assess the ratio of the diameter change at the level of the compression versus at the level where the vessel is dilated. So nutcracker syndrome represents vascular compression disorder. Again, usually you look for this aliasing in the left main renal vein and a caliber change. That's all have to help you with the diagnosis. In this kind of patients also gonadal vessels may be enlarged, and a patient may have varices, scrotal varices if it would be a male population. Other things we're looking for when we evaluating renal arteries, we again interrogating the veins as well. So because sometimes patients may have a very vague symptomatology, and referring physicians don't really know exactly what's wrong with the patient, and they sent for evaluation of renal artery stenosis, but we do find a different kind of abnormality. In this patient, again, we have a big mass that extends into the main renal artery and also extends into the IVC distal to the renal mass, as well as above the kidney. And this was a renal cell carcinoma with thrombus, tumor thrombus extending into the main renal artery and IVC. You can also interrogate the IVC more proximally and going towards the heart and atrium and see if there is any extension of this tumor thrombus into the heart. Then the treatment would be different. This is a patient with a transitional cell carcinoma, and which is very vague, poorly defined cancer that involves not just cortex but also extends into the renal sinus, and in this situation it's also extended into the renal vein. And here the take-home point is that there is a collateral vein that is present, and when you're looking for venous flow, don't just look at the tiny little vessels and be satisfied with it, but assess the entire patency of the vessel. It has to be normal in diameter or expected in diameter, and make sure that you're not mistakenly looking at the collateral vessel and completely missing the thrombus within the main renal vein. And this is on FOS, and also the thrombus was extended into the IVC in this patient. So as a take-home point, ultrasound is a powerful tool in non-invasive evaluation of renal arteries and veins. Peak systolic velocities, ratio of renal arteries to aortic ratio, and presence of Tardus parvus waveforms are major criteria for renal artery stenosis diagnosis with a high sensitivity and specificity. And just remember that combination works the best. And there is still controversy exists regarding revascularization, but there are patients who benefit from it and have a restored renal function, so it is useful. And there is a different renal vascular pathology that you have to be aware of when these patients are sent for evaluation of renal artery stenosis, as you can diagnose other pathologies that may cause elevation of peak systolic velocities, and also can diagnose other abnormalities that may present with a vague symptoms, and referring physicians may not know about it. I wanted to thank everybody for listening to our lecture, and if you have any questions, I'm ready to answer them.
Looks like we have several, Dr. Revzin. Are you able to see them? Are they coming up on your question bar?
Now let me see. Can I escape this right now? Okay. Questions.
And if they're not showing up, I'm more than happy to read them for you.
No, I'm seeing them.
Okay.
So one of the questions was, do you correct for angle when calculating velocities and resistive indices? So usually you wanted to correct angle when you evaluate in the main renal arteries, but you do not evaluate the segmental renal arteries. You don't do the angle correction for segmental renal arteries. I hope I explained this. I'm not sure if this is exactly what you're asking for. Let me see. So, and usually when we evaluate the peak systolic velocities, we use angle correction before we obtain the waveform. And you can do a post-processing angle correction as well. And you can calculate velocities as well at that time. Resistive indices, you evaluate by division of the peak systolic velocities, and therefore they're going to be also angle corrected. So next question would be, do you have any examples of technical errors suggesting stenosis in patients without the disease? So in technical errors would be there's abnormal angle correction that will spuriously elevate peak systolic velocities, and you may misinterpret it as elevated peak systolic velocities. Also, if the sonographer is not recognizing that the vessel is very tortuous and takes peak systolic velocity at the level of abrupt sort of change in the course of the vessel. And other things, I think that's the main reasons why the peak systolic velocities could be abnormally elevated and suggest stenosis. Okay. Are there any instances of venous abnormality signals where you would consider portal hypertension? Is power Doppler, oh, that's a different question. Okay, so are there any instances of venous abnormality signals where you would consider portal hypertension? Usually not much. Portal hypertension is related to portal vein, and portal vein is a portal system, so you would not have any repercussions to the systemic venous flow that is coming from the IVC. So if it would be a problem with the heart, you may find some abnormalities that due to heart malfunction, but not usually due to portal hypertension. Is power Doppler better to detect renal infarct? Yes, I think that power Doppler really amplifies very small velocities that can be found within the renal parenchyma, and therefore even if there is going to be some perfusion present, it will show it, and color Doppler may just show absence of flow. Also, if you don't find on power Doppler any flow within the cortex, then you could be more certain that there is definitely no flow and there is a probably infarct or maybe an abscess in the cortex of the kidney. Also, power Doppler is independent on the direction of flow, so it's not gonna, it's not gonna depend on this 90 degrees to the vessel, and which will show like no flow within the vessel. So it's really power Doppler is better. So another question is about, I have done this for nearly 20 years and struggle a lot more than you seems to. The patient seems to be unable to hold breath, have calcified vessels and big bellies. What strategies do you use for such patient population? So what I teach our sonographers is that just use your patients and not just to perform the procedure, but apply a lot of weight, with your transducer on the abdomen, and gradually sort of like push into the belly. And it's important not to just like push very quickly into the belly, but very gradual application of your weight into, so that will really remove the bowel loops from your course of your transducer and will really open up all the vessels much better. It works like a magic, especially in those patients who just either were not NPO or the patients who just very sort of gaseous. Also, I found that I usually keep patients supine and try not to rotate them just because the kidney is located posteriorly, and if you rotate the patient on decubital position, then they may, the kidney will descend a little bit and be a little bit further away from you, so it's going to decrease the ability to get a Doppler signal from these vessels. So I just come from the side and behind the patient, but keeping the patient in supine position. That will minimize the distance from the transducer to the kidney and help me to visualize the vessels better. So the other question is asking how long do the renal artery stenosis examinations usually take? Usually we allow 30 minutes for it, but if you cannot see anything within 10 minutes or so, just quit. Because if you cannot find origins of the vessels, you're still going to produce a limited exam. So therefore, there is no need to keep on sweating and trying to get, results, just because even if you're going to get the higher waveforms or mid portion of the main renal artery waveforms, if you don't see origins, it's going to be a limited examination, and as a physicians, we will always refer to further modality, like different modality, to be assessed. The main renal arteries. So we usually quit if we see that it's not going to be really possible to do this procedure. So there is another question which is asking, do we have to interrogate the arcuate artery? We used to interrogate arcuate artery, and we showed that there is no really any benefit to it. So it just adds additional time to scanning. Interrogation of segmental vessels is sufficient enough to find the Tardus parvus waveforms and also see the perfusion of the kidney. So we don't go into the arcuate arteries any longer. Another question is asking about resistive indices. Is it significant or not this time? So we found that, and I think it was also reported in multiple different papers, that resistive index is not really helpful in diagnosis of renal artery stenosis. In 50% of patients, it would be greater than 0.75, and in 50% of patients, it would be normal, less than 0.75. And 0.75 is considered to be a threshold to call it high resistive index or not. So we usually use a resistive index to say that there is a probably kidney medical renal disease or any other process that may be affecting the kidney, but it's a non-specific abnormality if we detect greater than 0.75 resistive index, and we don't usually use it for evaluation of renal artery stenosis. And the last question is, if the kidney is less than 8 centimeters, do you still complete the renal artery stenosis exam? So I personally think that at the end you don't really need to complete the exam if, depending on what kind of surgeon you're dealing with, because again, if the kidney is atrophic and less than 8 centimeters, then most likely it's not going to benefit from revascularization. However, sometimes physicians who refer the patients, they just wanted to know if there is any other reason why the patient may have elevated peaks, may have a renovascular hypertension or just hypertension. So by stating to them that something is abnormal, like if we do find stenosis, we could just solve their sort of quest for diagnosis. What is the patient have? And then they can decide if they wanted to do anything with it, or most likely they will not. But at least they're going to have an answer to their question and maybe narrow their differential diagnosis if we diagnose it as a renal artery stenosis. Okay, I think that would conclude all of the questions.
Great. Thank you so much, Dr. Revzin, and our thanks to all of you who participated tonight. We hope you enjoyed this presentation and will join us again for future webinars. Good night, everyone.
Good night.